Okay, our today's lecture is on uh, pain management, and in pain management, the use of opioid analgesics. Because when we say pain management, we have other group that already we have discussed, like acetaminophen, that is paracetamol, NSAID group, non-steroidal anti-inflammatory drugs, in which we have aspirin and COX-2 selective inhibitors and other non-selective COX inhibitor, in which we have naproxen, diclofenac sodium, naproxen, mefenamic acid, right? So, because all these group already we have discussed, so that is why there is another group, that is the opioid analgesic, that we will discuss. You know, there are different types of pain, non-ulcer origin, non-cancer origin pain, cancer origin pain, right? And somatic pain, visceral pain. So there are different types of pain. But main point is the pain which is associated with cancer, and this pain is due to tissue damage or due to use of chemotherapy, right? So this pain sometimes cannot be controlled with NSAID group, with acetaminophen or other groups. So in this situation, we'll have to give the opioid group, opioid analgesics, right? And the pain at the end of life, right? When there is a term that we say palliative treatment. You know, at the terminal stage, when all the therapies, they are showing the failure, right? Patient is not responding, or therapy is useless, and ultimately patient has to die. So the palliative treatment means now we are going to provide the sound death to our patient, right? Pain-free death. So in that situation, we can use opioid analgesics. And there are other clinical uses that we will discuss later on. But the main point why we are not using opioid group as a common group, right? Because one of the problem is its addiction potential, right? Its addiction potential. There is a chance of drug dependency. And what is drug dependency? That we will also discuss in the subsequent slide, because there are two type of drug dependency: physiological drug dependency and psychological drug dependency. So clear? So why or when we use this group? We cannot use this group commonly because this group has some serious side effects. There are specific conditions when application of conventional antacid, NSAID or other painkillers are no more effective. Okay? Okay, opioid analgesic, also called narcotic analgesics, analgesia that we know relief of pain without loss of consciousness, right? So, opium. What is this opium? Okay, I have shared the screen. Tariq? स्क्रीन शेयर हो रही है? Okay, thank you. Thank you. Thank you. Okay, now we are going to continue. Okay, opium Natural extract from poppy plant used for social and medicinal purpose for thousands of years to produce euphoria. You know, euphoria, feeling of forgetfulness, right? Uh, Hyper excitable stage, and because of this euphoric feeling, uh, persons or patient become addicted to this growth, right? So euphoria, analgesia, sleep, and to prevent diarrhea. Opioid drugs, natural as well as synthetic, morphine-like drugs, because the prototype drug of this group is morphine, right? Opioid analgesics and antagonists. Important classification, strong agonist, right? That we will see what does it mean, strong agonist, because there are certain receptors at which these drugs bind and produces its activity. So these are the examples: alfentanil, fentanyl, heroin, mapridine, methadone, morphine. This is the prototype drug of this group: oxycodone, remifentanil, and sufentanil. And moderate agonists include, we have codeine, propoxyphene, right? So these are moderate agonists. Mixed agonist, pentazocine, nalbuphine, butorphanol, and buprenorphine. That means this group, clinically, commonly, we are using in our ward this group because having mixed agonist as well as antagonistic activity, so chances of less addiction potential is there, no doubt. But if we compare with strong agonists, the chances of drug addiction are less if we compare with strong agonist, right? So that is why clinically we are using nalbuphine commonly in our, especially in surgical ward where we are required the opioid analgesic, right? Buprenorphine. Okay, opioid antagonist, we have naloxone, naltrexone, and nalmefene. And this concept, I think, at this level, all of you must clear this concept that sometimes when there is overdose of agonist, right? So how we can overcome this overdose effect? By giving antagonist, and this is one of the question that is asked: if there is overdose of opioid analgesics, so how we can overcome this problem? We will say we will give opioid antagonist. Okay, what are the examples of opioid antagonists that can be used to overcome or reverse the toxicity or overdose of opioid agonists? We have naloxone, we have naltrexone, and nalmefene, right? So this is important. And what we have discussed, I am repeating again. So clinically, morphine is not being used commonly, but it's being used. But clinically, or in our clinical setup, in our hospital setup, if there is a need, so generally we use mixed agonist antagonist opioid group, in which we have nalbuphine, and a very famous name, famous market name is Skin's injection, right? That is related to this mixed agonist antagonist group. Now, these opioid receptors. The opioid agonists act at specific receptor sites to produce their pharmacological effect, right? And we have three types of opioid receptors: mu receptors, kappa receptors, and delta receptors, right? So these are the three major types of opioid receptors. They are for endogenous opioid-like substance, which also stimulate opioid receptors. So these are the endogenous substances like enkephalin, that is metenkephalin or lewenkephalin, beta endorphin, and dynorphin. So these are the endogenous substances that can also stimulate these receptors. So this is the diagram of mechanism of action of opioid analgesics. Morphine, they are going to bind with receptors. And what will happen? Morphine binds opioid receptors and thus impairs the normal sensory pathway. How? Number one, blockade of calcium channels, which leads to decreased release of substance P and glutamate from the first neuron of the sensory pathway in substantia gelatinosa, in spinal cord and medulla. Number two, decrease cyclic AMP. So what will happen? Decrease cyclic AMP, which leads to opening of potassium channels and hyperpolarization of the second neuron of the sensory pathway. Now, effects due to mu receptor stimulation. This is important. And it will produce the effect at the supraspinal level, that means at the higher central level, spinal and peripheral analgesia. And one point is very important. Anything which is acting at supraspinal level, that means at higher central level, increased chances of euphoria. Increased chances of euphoria. If a drug having strong mu receptor agonist activity, so that drug will show the high euphoric effect. That means high potential of drug addiction. Okay? So supraspinal, spinal and peripheral analgesia, euphoria, respiratory depression. So this is the problem. This is the problem that can cause death. This is the problem that we cannot use opioid analgesic. Commonly, meiosis, that is the pinpoint pupil, decreased GIT motility, and because it decreases GIT motility, so some of the opioid derivatives can be used in the treatment of diarrhea. That we will see in the subsequent slides. Sedation and physical dependence, right? And this we will discuss in detail what is the difference between physical dependence or psychological dependence. You know the drug dependency, that means if a patient is taking a drug and when that patient leave that drug or quit that drug, so body will show the reaction because that patient's body now dependent on that drug. Right? If the body is going to show the response, that is called the physiological drug dependency. When the body is not showing the reaction, but there is a craving, only craving, that is called the psychological drug dependency. Let me explain through one example. You know, when a person having is a chain smoker, but during Ramadan, during fasting, he is not going to use cigarette during whole this period of fasting, right? So definitely he will show some craving, some irritability, but his body is not going to show the any reaction, right? This is called the psychological drug dependency. Similarly, a patient having a person having taking tea and coffee, totally dependent on this. But during Ramadan, if that person is not taking tea or coffee continuously, so he or she can live without this. Okay, body some irritability or craving, but body is not going to show the response. But if a body is not under the control of that person, that is called the physiological drug dependency or physical dependency. So which one is dangerous? Physical drug dependency or psychological drug dependency? Quickly tell me. Someone. Which one is dangerous? Physiological drug dependency is dangerous or physical? Very nice, right? So, okay, very good. Effects due to kappa receptor stimulation is spinal and peripheral. Now you can see there is no supraspinal activity, right? So that means chances of euphoria are less, right? But sedation, respiratory depression, they are there just like mu receptor stimulation, but less than mu receptors. Meiosis, less, decreased GI motility, and physical dependency, same. Effects due to delta receptor stimulation, spinal analgesia, only spinal analgesia. It provide only spinal analgesia, respiratory depression, and decreased GI motility. So one point is very important that at least you must know. What is that? That the drugs, whether it's stimulating mu receptor or kappa receptor or delta receptor, chances of physical dependency is there. This is common. Okay, as far as the euphoria is concerned, mu receptor stimulation, if a drug showing mu receptor stimulation, so it will show the euphoric effect more than other receptor stimulation, because this activity is due to supraspinal activity. These points at least you must remember. Now this morphine, because morphine already we have discussed, the prototype drug of this group. So any opioid compound activity, we can say this compound showing the activity like morphine. So effective orally, but is much less effective. Why? Because of extensive first pass effect. We can give morphine orally, but high doses are required, because most of the orally administered morphine is going to be metabolized due to first pass effect. So, but when given parenterally, due to first pass, this if we compare, when it is showing the maximum concentration, when we give parenterally or orally, right? Orally, it's showing the maximum metabolism, first pass effect, so less concentration is achieved. But parenterally, maximum concentration. That means morphine will show the activity, full activity, when we use morphine parenterally, right? We can give orally, but for oral administration, we are required the high doses. So that is why we do not use morphine or opioid compound orally commonly, but there are some opioid compounds that can be given orally, and that we are giving orally nowadays in our clinical practice, that we will discuss in the subsequent slide. And one of the common example of orally given opioid compound, that is the tramadol or tramadol, right? That we will discuss. Metabolism involves glucuronide formation, the product of which is excreted in the urine. Now, what are the different pharmacological effects? What are the effects that we will observe on central nervous system? Morphine has mixed depressant and stimulatory action on the CNS, but depressant effects predominant in human. Analgesic effect, drowsiness is common. Continuous dull pain relieve more effectively than sharp intermittent pain. Most patients indicate that they can still feel the pain, but it no longer bothers them. Morphine is an agonist at mu and opioid, kappa opioid receptors. Euphoria and sedation. It is mainly due to activation of mu receptor. And this point already we have discussed. Emesis means vomiting. Emesis means vomiting. So this is one of the drawback of this opioid analgesic. Because in the beginning, when we were discussing that why we are not using opioid analgesic, right, commonly, right? So this is one of the problem, emesis. That means induction of vomiting. Morphine directly stimulates the chemoreceptor trigger zone, usually transient, and disappear with repeated administration. Anti-anxiety effect, this is the positive effect. Meiosis, that is the pinpoint pupil. It is due to stimulation of anterior-vespal nucleus of the oculomotor nerve. And sometimes in emergency, If a patient come to the emergency department, so after taking history and when we observe the patient, so if the pinpoint people is there, so we can think about the overdose of opioids, right? Cough reflex is inhibited. This action surprisingly doesn't correlate closely with analgesic and respiratory depressant effect opioids, and its mechanism of action at receptor level is unclear of morphine. With chemical modification, codeine and pholcodiene, the antitussive effect can occur at sub-analgesic dose. So that is why you can find in different cough syrups, you will find one of the codeine and pholcodiene, right? So these are the substances that can be used as antitussive. Respiration is depressed. This is important point. Due to a direct effect on the brainstem respiratory center, death from narcotic overdose is nearly always due to respiratory arrest. It occurs at therapeutic doses, but not accompanied with cardiac center depression in contrast to other CNS depressant like general anesthetic agents, right? So in case of opioids, it only suppresses the respiratory center, but not suppresses the cardiac center. But if we compare with general anesthetic agents, not only suppresses the respiratory center, but also suppresses the cardiac center. Other effect, morphine is a basic drug that causes the release of histamine, right? So causes the body to feel warm and the face, nose to itch, bronchoconstriction and hypotension. So this is one of the important point. Morphine, it can release the histamine, right? So it may produces itching or bronchoconstriction and hypotension. So one of the important point we can correlate clinically. So in which condition, in which disease, in which problem, we have to be very, very careful if we are going to use morphine or other opioid analgesic. Anyone? Okay, there is a reply. Asthma, very good, very nice. So this is the point that we must know, that we must be able to correlate, right? And there is another problem if a patient having hypotension, so it will further decreasing the blood pressure. It also abolishes hunger, right? It dilates the cerebral vessels and increase intracranial pressure. So again, one of the problem, one of the condition in which we'll have to be very, very careful, because you know, when there is a need to give the powerful opioid analgesic in emergency situation, right? So, but there is a emergency situation, but in that situation, we'll have to be very, very careful. What is that situation in which we can correlate this point, dilatation of cerebral vessel and increased intracranial pressure? If a patient come to the emergency department with which problem? With which problem? Anyone? Okay, there is a reply. Headache, head injury, right? Head injury. When a patient come to the emergency department with head injury or intracranial pressure due to meningitis, right? So other space occupying lesion, right? So we'll have to rule out, first rule out, then we can administer this opioid analgesic. Okay. Cardiovascular effect, postural orthostatic hypotension. It is primarily due to decreased vasomotor center activity, leading to peripheral vasodilatation, which may be due in part to histamine release, right? In congestive heart failure, morphine decreases the left ventricular workload and myocardial oxygen demand. So this is another very important point that we can correlate clinically, and there is a condition in which in emergency situation in which we administer morphine, and it is being used because I have done my house job in an ICVD in cardiac unit, and I have seen personally, especially in which situation, in which condition oxygen demand is increased. So we can use morphine to get this important point because it decreases the left ventricular workload and decreases the myocardial oxygen demand. Okay, here is a reply. We check it. MI. Very good. MI. Very good. So, okay, continue. Endocrine effects. It increases prolactin secretion, increases vasopressin ADH secretion, so it will cause oliguria, decreases pituitary gonadotropin, LH, and FSH secretions, decreases stress-induced adrenocorticotropic hormone secretion. So these are the important points related to endocrine effect. Gastrointestinal effect. So one of the important point already we have discussed. One of the activity of morphine or opioid related compound is to decrease the peristaltic activity. So it decreases the motility and increases the tone of the intestinal circular muscle and the tone of the anal sphincter. It also causes contraction of the gallbladder and constriction of the biliary sphincter. Constipation, tolerance does not develop to this effect. What does it mean? This is important point. Okay, you know, first of all, we must know what is tolerance so we can understand this concept. Tolerance is the decrease drug response, gradual decrease in the drug response, right? That means if a patient is taking a drug, after some times, what will happen? We are not going to get that effect, right? So that means, suppose one of the activity already we discussed that like vomiting, MSS, you know, but with the repeated administration, this problem will not occur. MSS, vomiting, right? So in the previous slide, we have discussed one of the effect of opioid analgesic is to produce the MSS, right? But with the repeated doses, against this effect, tolerance is developed. So after repeated administration, now vomiting will not occur. This is called tolerance. But against this constipation, that means even after repeated administration we cannot overcome this problem. So this is one of the problem. If we especially if we start the therapy with opioid analgesic, in the subsequent slide we will discuss that one of the preparation that we give orally nowadays in our clinical practice is the tramadol. Tramadol injection is available, tramadol capsules are available. So if we are prescribing this preparation, we are also prescribe stool softener, right? Stool softener to avoid the constipation, because this is one of the effect against which tolerance doesn't develop. Clear? So diphenoxylate and loperamide, these are the preparation, these are the compounds, opioid derivatives, can be used in the treatment of diarrhea. They decrease GI motility and peristalsis. But again, one of the important precautions before starting, because it increases the tone, you know, increases the tone. So before starting these drug or opioid derivative, we must rule out that is there any intestinal obstruction is there or not, right? Otherwise, we can rupture the lumen due to increased pressure. This is very important point. Genitourinary effect, morphine prolong the second stage of labor by decreasing the strength, duration, and frequency of uterine contraction, inhibit urinary bladder voiding reflex, And sometimes catheterization may be required in some cases. So sometimes this morphine prolong the second stage of labor by decreasing the strain, duration, and frequency of uterine. So there is a chance of delaying of the labor, right? Delaying of the labor. And inhibit urinary bladder avoiding reflex. So one of the important point we can correlate with this. This means if a patient having a history of prostate hyperplasia, benign prostate hyperplasia in which already patient is unable to micturate properly, so this will exaggerate his problem, right? So we'll have to be very, very careful to give morphine in a patient having a history of benign prostate hyperplasia. Adverse reactions, generally direct extensions of their pharmacological actions, respiratory depression, apnea, nausea and vomiting, dizziness, orthostatic hypotension, edema, mental clouding, and drowsiness. Constipation, paralytic ileus can occur, biliary spasm, colic pain, dry mouth, urinary retention, urinary hesitancy, hypersensitivity reactions, contact dermatitis, urticaria, immunosuppression, so recurrent infection. Precautions, respiratory depression, particularly in newborn and patient with chronic obstructive pulmonary disease. So these are the precautions. Orthostatic hypotension, histamine release asthma that already we have discussed. Drug interactions. That means suppose a patient already taking some CNS depressant drug, right? And we will further add morphine. So it will produce the additive effects. So severe CNS depressant effects. So this will have to be very, very careful. Tolerance and cross tolerance to other opioids. Benign prostate hyperplasia. This point already we have discussed may precipitate urinary retention. Drug dependency, and this already in the beginning of the lecture already we have discussed in very much detail. There are two types of drug dependency, psychological drug dependency and physiological drug dependency. Psychological, that means if a person is not taking that substance, that person will show craving, right? Some irritability, but body is under his or her control. But in physiological or physical drug dependency, body is not under control of that person will, right? Liver diseases due to accumulation of the drug, increase intracranial pressure and head injury. It enhances cerebral ischemia. Therapeutic uses, analgesia, so myocardial infarction, right? This point already we have discussed. Terminal cancer, this point also we have discussed. In surgery, in obstetrical procedures, but in surgery, in obstetrical procedure, we are using which type of opioid agonist? A strong agonist or mixed agonist, antagonist? Because this point already we have discussed. Mixed, very good, very good. Dyspnea due to pulmonary edema, this is another very important condition in which we use morphine, right? Severe diarrhea, right? So these are the therapeutic uses. Now, other opioid analgesic, there is very famous, well-known heroin, right? Not the film heroin, right? This is diacetyl morphine, right? So diacetyl morphine, that is called heroin, and mu agonist. So mu agonist, that means increased chances of what? This point also we have discussed. If a drug showing strong mu agonist activity, increased chances of euphoria. So increased chances of drug addiction. Very nice, very nice. That means all of my students are very much attentive. It's a good sign. Heroin is more lipid soluble, and this is why, you know, this substance kept under the scheduled 1 drug, right? Scheduled 1 drug. Heroin is more lipid soluble than morphine. So that is why it is very dangerous, right? And about 2.5 times more potent. So addict of heroin, where they are very devastating. And if a patient becomes addicted of heroin, it enters the CNS more readily. It's a Schedule 1 drug and is not used clinically, but it's a drug of abuse. The reason? Any drug increase, any drug, if having increased chances of drug addiction potential, that means that drug is showing the strong euphoric effect, and this strong euphoric effect is due to strong stimulation of mu receptor. Codeine, from opium or synthesized by methylation of morphine, has a much better oral parenteral absorption ratio than morphine, effective for mild to moderate pain, cough, and diarrhea. Has a more potent histamine releasing action than morphine. Dependence liability of codeine is less than that of morphine. Dextromethorphan, excellent oral antitussive, and you can check it yourself if you have any cough syrup, if at your home, or you can find somewhere, and like one of the cough syrup is Benadryl, or there are number of other cough syrups, you will find dextromethorphan in the ingredient of that cough syrup, right? So excellent oral antitussive activity, but no analgesic effect, no GI effect, no respiratory depression, right? So this dextromethorphan you will find in cough syrups. Mapridine, there is another name of this mapridine is pethidine, produces analgesia, sedation, euphoria, and respiratory depression, less potent than morphine. 80 to 100 milligram mapridine equals to 10 milligram of morphine, right? So shorter duration of action than morphine. Mapridine has greater excitatory activity than does morphine, and toxicity may lead to convulsions. Mapridine appears to have weak atropine-like activity. That means atropine-like activity. So if a drug showing atropine-like activity, what does it mean? It will show the cholinergic agonist activity or cholinergic antagonistic activity. It will show the anticholinergic or cholinergic antagonistic activity. So you know what it will do. It will decreases the peristaltic activity, or it will decreases the secretions, right? So we can correlate with anticholinergic activity. So it does not constrict the pupils to the same extent as morphine, does not cause as much constipation as morphine, purely synthetic mu agonist, not an effective antitussive agent, less effect in uterine contraction, also causes less urine retention. One important point I want to discuss with you. What is that? Only one problem related to this mapridine. And what is that? That is the higher excitatory activity than morphine. This is one of the little drawback of this drug, and it may lead to convulsion. Otherwise, it is less potent than morphine, so it is not going to cause constipation. And one of the important point in obstetric, you know, in case of morphine, morphine can delay the second stage labor. So that means we cannot use, if there is a need to strong, powerful analgesic, we cannot use morphine. right? But mapridine can be used because less effect in uterine contraction, right? So that is why commonly employed in obstetric, and also cause less urine retention. That means if there is a need to give the powerful opioid analgesic in a patient having a history of benign prostate hyperplasia, we can use this mapridine. But one problem you must know, you must keep in your mind, that if this patient having a history of epilepsy, having a history of convulsions, we should avoid to give this mapridine. Adverse reaction to mapridine, respiratory depression, just like other opioids, tremors, delirium, and possible convulsions, dry mouth is because of weak atropine-like activity, severe reaction if given with monoamine oxidase inhibitors, consists of excitement, hypothermia, and convulsions. It is due to accumulation of pethidine or norpethidine metabolite. Now, this is another drug, fentanyl. And this is one of the important drugs nowadays in our clinical setup, in hospital setup, usually in surgical setup, right? Mu agonist related chemically to mapridine, approximately 80 times more potent than morphine, and main use in anesthesia. So this is the point I wanted to share with you. This fentanyl is one of the important drugs that is being used in our hospital setup, in especially in anesthesia. Duration of action very short, 20 minutes. So that means for short surgical procedures, we can use this fentanyl, right? Can be given intramuscular, intravenous, transdermally, or via patient control infusion system, right? Or maybe given intrathecally. Often used during cardiac surgery because of its negligible effect on the myocardial contractility, right? So this is important point. So in cardiac surgery, we use opioid derivatives, and one of the important example is fentanyl, right? And there are other derivatives related to this fentanyl, L-fentanyl, sufentanil, remifentanil, right? So there are other drugs. Sufentanil, a synthetic opioid related to fentanyl, about 7 times more potent than fentanyl, has a slightly more rapid onset of action than fentanyl, right? Methadone. So this is very important drug. You know, that we will discuss why it is supposed to be a very important drug, this methadone. It belongs to a strong agonist group, right? Pharmacologically and analgesic potency is similar to morphine, mu receptor agonist, very effective following oral administration. This is one of the points. Very effective following oral administration. You know, morphine is not very effective if we administer orally due to extensive first pass effect. And second important point of this methadone, longer duration of action than morphine due to plasma protein binding ability. Approximately half-life is 25 hours. So longer half-life, longer duration. Now, this is the point that you must focus. Use in methadone maintenance programs for treatment of opioid addicts and for opioid withdrawal symptoms, right? It reduces the physiological abstinence syndrome, make it possible to wean the addict from opioids. You know, when we suppose a patient is addicted of opioid or morphine, so we cannot stop. So we cannot suddenly stop that morphine or that opioid. What will happen? The patient will show the abstinence syndrome or withdrawal syndrome, right? So body will show the reaction. That patient may die, right? So in that situation, we can use another strong mu agonist, that is methadone. So gradually we are going treat that patient gradually, because methadone were very effective orally, longer duration, right? So gradually we can decreases the craving for morphine, right? Propoxyphene, a methadone analog used orally to relieve mild to moderate pain. It is weak analgesic, often combined with paracetamol. So you can also find some preparation, right? Painkillers in which you can find this opioid derivative propoxyphene, right? Has a low addiction potential. This is the problem, has a low addiction potential. But sometimes when we think, okay, if a patient is exaggerated and we have to calm down that patient, so we can use this combination, right? Because this patient, this propoxyphene will show the sedative effect, right? Calming effect. The most common adverse side effects are dizziness, drowsiness, nausea, and vomiting. CNS depression is additive with other CNS depressant. This point also we have discussed related to drug-drug interaction, right? Like if a patient is taking alcohol and already taking some sedatives, right? So it will further, if we use further this propoxyphene, it will further depress the CNS. Can cause cardio-toxicity and pulmonary edema, which cannot reverse by naloxone. So this is one of the point that this preparation, this compound is not being used commonly, right? Even if there is an overdose of propoxyphene, we cannot reverse its activity by giving opioid antagonists like naloxone. In the beginning, we discussed that two important, there are three opioid antagonists, nalmefene, naloxone, and naltrexone. Now, this mixed narcotic agonist antagonist, important points already we have discussed. These drugs produce analgesia but have a lower potential for abuse and do not produce as much respiratory depression, like pentazocine, that is the kappa agonist, and mu antagonist. That means there is no chance of euphoria, right? Less respiratory depression. Orally, it has about the same analgesic potency as codeine. Adverse reactions to pentazocine: nausea, vomiting, dizziness, dysphoria, nightmares, and visual hallucinations. Rarely used nowadays, this pentazocine. Nalbuphine. This is the compound that is being used extensively, especially in our surgical units, right? Especially after post-operatively to relieve the pain. Resembles pentazocine pharmacologically. Like morphine, nalbuphine reduces myocardial oxygen demand, may be of value following acute myocardial infarction due to both its analgesic properties and reduced myocardial oxygen demand. This already we have discussed. Most frequent side effect is sedation. Less propensity to produce psychotomimetic side effects. Psychotomimetic means like nightmares and visual hallucination that we find in pentazocine, but we are not going to find in this nalbuphine. Okay, buprenorphine, a partial agonist at mu receptors, 200 times more potent than morphine. Low potential abuse, but can precipitate withdrawal in addicts. In naive person, it acts like morphine, right? In naive persons, that means a person doesn't have any opioid in his or her life. You are administering first time. So in that person, it will produce the activity just like morphine. Major uses: office-based detoxification of opioids, causes less sedation, respiratory depression, and hypertension, even high doses. So that is why this buprenorphine major use is office-based detoxification of opioids, right? Now, this opioid antagonist, naloxone, pure opioid antagonist at all opioid receptors given parenterally can precipitate withdrawal in addicts. Because if we suddenly stop the activity of opioid, it may show the addiction. Office-based detoxification means in the when will have to admit heroin addict patient in the center, right? But in some patient, if we are not interested to admit our patient, so in that situation, we can use this drug, right? Suppose I am not interested to admit my patient. So because if we admit our patient, so there is a protocol, we use methadone gradually, right? So if we want to get emergency treatment, so we are not interested to admit our patient, so we can use this drug. So that is the explanation of office-based detoxification. Naltrexone, oral pure opioid antagonist, long duration of action, right? So that is why less chances of withdrawal reaction. Contraindicated in liver disease. Use in late stages of opioid addiction treatment, also in treatment of alcoholism. Nalbuphine, long-acting parenteral opioid antagonist. So at least you must remember the name of opioid antagonist. Clear? So this is all about the opioid analgesics. So the key points already I have repeated again and again, right? So one thing you can also you can say this is just like your activity that you can perform when there is a chance to go to the ward, right? After this COVID, if you have the opportunity to round the ward, especially in surgical ward, you can check it. What are the opioid derivative injectable forms that we are using in our setup, right? So thank you so much. Okay.